I'm Cristiane Carvalho, and today is my pleasure to welcome Professor Peter Pickers, who will share the most recent results on the new formula using Proenkephalin A to estimate the GFR. Professor Pickers is Professor of Intensive Care Medicine at the Radboud University Medical Center, and his research focuses on pharmacological modulation of the innate immune response in translational models and patients, and the consequence for organ function, with special interest in the kidneys. Professor Pickers is co-author of over 500 articles in the field of sepsis and nephrology, and over 30 book chapters. Last but not least, I would like to share a few information with you on this webinar. This webinar will be recorded and later available online. During the webinar, please type your questions in the text field, and we will read them in the QA session in the end of Professor Pickers' talk. With that, I would like to give the word over to Professor Pickers, and thanks again, Professor, for being with us today.
Thank you very much, and it's a great pleasure. Hello, everybody. Good morning, good afternoon, good night, wherever you are in the world. The next 1 hour, we're going to discuss Proenkephalin, and as this may be a novel biomarker to estimate the GFR in patients. And I will give you a very short one-slide background to start with, because people that are looking at this webinar know a lot about renal function, AKI, and critical care patients already, I assume. So, acute kidney injury is a very prevalent syndrome, especially in patients in the hospital or in the ICU. Up to 50% of patients in the ICU actually have acute kidney injury, and this is associated with both morbidity as well as mortality. And if over time the renal function gets more impaired, then mortality is higher in that subgroup. And if renal function is improving, then survival is better in that subgroup. So it's clearly related to morbidity and mortality. And apart from the period of time in the intensive care or in the hospital, acute kidney injury is related to a higher chance of end-stage renal damage. And clearly, an impaired renal function is a huge burden for both the patient as well as society, because it's very expensive to treat. So the diagnosis of acute kidney injury is mainly based on creatinine. We do have the urine output criterion as well as the creatinine criterion, but still, if the diuresis is a little bit low for a couple of hours, this is not really viewed in the clinic as acute kidney injury. So mainly based on the creatinine level, renal damage is being diagnosed. And of course, we can measure creatinine very easily, and we do know that there is indeed a relationship between the GFR, what we take as a measure of renal function, and the creatinine value circulating in the blood. The problem is, however, that this is not a linear relationship. And that means that there are huge differences depending on where you start. If you have a creatinine value that is normal and your GFR is between 100 and 120, you can actually lose a lot of GFR before the creatinine value will start to increase, as you can see here. To illustrate this, you can see that indeed the GFR has to impair from 120 to 60 mils per minute per 1.73 square meters before the creatinine value will actually surpass the upper limit of normal. So there's a huge amount of nephrons that's being lost before you will actually detect an increase in creatinine. And then if renal function is getting worse, then much smaller decreases of GFR are detected by a much more pronounced increase in creatinine. So apart from the fact that it's really insensitive, especially when you start out with a normal renal function, the other problem with creatinine is it's slow. If in experimental models you would actually decrease the GFR all of a sudden to 10% of the normal value, it will take up to 2 days before you will detect an increase in creatinine. And if the GFR is slowly improving again, creatinine is still peaking, and it will take another 2 days before the decrease in creatinine is happening. And the overall problem with creatinine is that it's both insensitive and late. And so my wife tells me that those two combined are really bad combination. So why is this? Well, creatinine is filtered in the glomerulus. Okay, that's what we need to estimate GFR. But the issue is that there is reabsorption and active excretion. So if creatinine in the blood is really high, there will be actual excretion from the blood into the urine as well. And therefore, the increase in the blood is not as swift and pronounced as you would expect if from only filtration. So this is one of the problems with creatinine. Now, why is this an issue? Well, clearly we know that if renal damage is progressing, the therapeutic window to do anything about it is getting smaller and smaller. And so as creatinine is one of the late biomarkers, the window is already very small, and so there's little we can do to further prevent or to treat AKI, as irreversible damage might be done. Now, some people say, well, this is true, but there is no specific treatment for acute kidney injury, so who cares if you know it a little bit later? Well, even though there is no specific treatment for acute kidney injury, there are multiple things that we can do, as is depicted here from this figure from the KDIGO guidelines, that you should do in patients that are at risk or have already beginning acute kidney injury. You will do secondary prevention things like discontinue all nephrotoxic agents when it's ever possible. You will have more profound hemodynamic monitoring, etc., etc. So there are many things you can do to prevent further damage in these patients, even in the absence of a treatment of acute kidney injury treatment. Yeah. So this is actually representing a catch-22. The thing is that people would say, well, we have no treatment, so there's no need for a timely biomarker. It's fine if I need it 1 day later. But the issue is that without a timely biomarker, there will be no treatments found ever because the damage is already done. So we do need to look for new biomarkers that are more current. There's only one thing worse than a catch-22, and that's a catch-22 situation, I think. So this is recognized, and as you can see in this intensive care medicine agenda for acute kidney injury, it is clear that creatinine and the urine output criteria are late functional biomarkers, and if you want to detect a decrease in GFR, you would need an early functional biomarker, and before that, there might be biomarkers that could actually detect injury, tubular injury. And so to bring the field forward, this is really what we need. So what is available to have a very good and current estimation or measurement of the GFR? Well, what is currently the gold standard technique is using Iohexol or iotelamate as a decay curve. So what you need to do is administer a small amount of Iohexol, and then within the next couple of hours, measure Iohexol in the bloodstream. So you need to take a couple of samples, and based on this, you can actually measure the decay curve and calculate what the GFR is. This is a very good measure. It's easy to obtain this. The radiology department has tons of it. However, it's really labor intensive. You have to administer the Iohexol and you have to take several samples from the patient, and then it's really difficult and expensive to do the determinations in the blood. So this is not done or used in clinical practice. The old gold standard was inulin, but that is no longer available anymore. And as you can see in this graph, in patients in the ICU, there's a huge variation if you compare the gold standard inulin against the creatinine clearance. So not only the plasma creatinine, which has even worse measure of renal function, but even creatinine clearance, there's a huge variation. And if we compare inulin clearance against the Iohexol, the contrast media clearance, you can see that the correlation is much, much better. So therefore now the contrast media clearance method is actually viewed as the gold standard. So creatinine is insensitive and late. Iohexol is very precise and current, but it's labor intensive, prone to mistakes, very expensive as well, so it's not used in the clinic. So what about Proenkephalin? How does this compare to Iohexol determined GFR? And if so, is penK earlier if you compare to creatinine to detect a difference in GFR, a change in GFR, and to detect AKI? Or can it also detect earlier an improvement in GFR following AKI? So what is this Proenkephalin? This is actually an endogenous opioid, which is produced in several places in the body, and it has several properties that make it a good measure of renal function. It's completely filtered in the glomerulus. There's no protein binding, and there's no active tubular secretion or reabsorption, as was the case with creatinine. And so that way it might be a little bit more swift in detecting changes of GFR. The problem with it was that it was really difficult to measure in the blood, and this is now solved by Swingotech, as it can measure Proenkephalin. So the thing is that it's not only cleared by the kidneys, but also the production is dependent on several things. So one thing, for example, as this was discovered, is that the heart is one of the organs where Proenkephalin is produced, and there's more pronounced production of Proenkephalin during heart failure. So if there is heart failure and acute kidney injury or worsening of renal function, then both more production and impaired clearance might actually show a more pronounced difference. And so you might wonder, well, endorphins in the kidney is a strange combination. And what is interesting also is that apart from the central nerve system, the highest density of receptors, opioid receptors, is in the kidney. So it's intriguing what it might do there. I will come back to that. So the idea and how this was discovered in heart failure patients is that during heart failure, indeed, there's an increase of Proenkephalin secretion, and if the kidneys fail, there's a decrease of clearance of the Proenkephalin. And so therefore, the concentration that you would measure in the blood, the differentiation becomes much more pronounced. At the same time, there are specific effects of Proenkephalin on the kidney. So if we look at a huge study in heart failure patients, indeed, apart from pre-existent renal failure, which is a predictor of getting worse renal function, is Proenkephalin. That is the best and highly significant predictor of worsening of renal function, much more than cardiac biomarkers or any other biomarker that was tested in this study. So as a consequence, if you look at the different quartiles of penK, the differentiation between event rates and also even mortality is much more pronounced compared to, for example, pro-BNP or other markers of heart failure itself. So the idea is that not only penK is cleared by the glomerulus, there's no tubular reabsorption or excretion, and therefore this is a renal marker. The idea is also that there's more produced and it's signaling to the kidneys that there might be danger coming. And indeed, Proenkephalin by itself has effects on the kidney, and it increases diuresis and has effects via the different opioid receptors. So comparing penK to creatinine, it's a similar filtration in the glomerulus, But unlike creatinine, there's no reabsorption or excretion in the tubuli. And this is a problem for creatinine because during AKI, you will have an overestimation of the GFR because there's active excretion into the urine. This is not the case for penk. And at the same time, there are feedback mechanisms that are also related to the regulation of penk in the bloodstream. So up to now, there's a huge amount of studies that's being conducted, observational studies in different diseases like sepsis or acute cardiac diseases in patients in the ICU or in the emergency rooms. And this is clearly showing again and again the associations with the development of acute kidney injury and even outcome. And I will give a short summary of some of these studies. First of all, penk is very well characterized in healthy volunteers, as you can see here. And you can see that the normal value is around 45 picomolar per liter. And that is actually a very small Gauss curve. And so there's little variation within the normal population. The second thing is that also different from creatinine, that it's not released from muscles. So we did a small study in healthy volunteers that actually did an exercise on a treadmill. And as you can see, if you do so, creatinine goes up because it's released from the muscle. So you might think there's AKI, but this is just released from the muscle. So this is different. And this was not the case in the same samples for proenkephalin. So this is another way of creatinine measures being influenced by something else. We also found that in patients in the ICU on renal replacement therapy, as we know, the machine also clears creatinine value. So creatinine level goes down in those patients on renal replacement therapy. And so therefore, it's difficult to decide if the lower creatinine is actually the consequence of better renal function of the patient, or is just a consequence of being on renal replacement therapy. This is again not the case with penk. As you can see here, penk levels are pretty stable even in patients on renal replacement therapy. So that means that if there is a change in penk levels, this is likely related to the renal function of the patient himself. So this is a study on a head-to-head comparison with a tubular stress marker, NephroCheck. I'm sure you know it. So these were critically ill patients again, and they selected a subgroup of patients in the ICU that were on mechanical ventilation and on a vasopressor. And what they found indeed was that if you compare it to KDIGO AKI criteria, so higher level is a higher severity of AKI, that especially in the patients that do not fulfill any AKI criteria, already the stress marker NephroCheck can be elevated. So in this case, it's high, but it's not associated with the development of any AKI later on. And as you can see in those patients, penk is still low. So there's better differentiation in that group that might not develop AKI, low levels of penk compared to already higher levels of the NephroCheck measurement. And indeed, the prediction of having AKI was better for proenkephalin against NephroCheck. And also, as a consequence of that, you might be able to predict who would need renal replacement therapy. And again, the penKid, the proenkephalin level, had an area under the curve of 0.78, while it was 0.68 for NephroCheck. So if you know more precisely renal function, you're also able to know more precisely the risk of needing renal replacement therapy. So based on all this, the idea is that the increase of proenkephalin might be earlier compared to serum creatinine if patients develop AKI. And also if AKI is resolving, the decrease in proenkephalin is more swift compared to the decrease in creatinine. So these are very interesting things to look at, and I will talk about it in the next couple of minutes. The kinetics of proenkephalin. So one of the first studies that was done was performed in patients with sepsis that presented in the emergency room. And as you can see here, there's a clear correlation with proenkephalin and the creatinine clearance. And this relates to rival criteria, for example. But what is even more interesting in my view is that indeed, if proenkephalin is high, you're more likely to die, but especially if it stays high. So if it's high the next day, then you're still more likely to die, while if it's lower the next day, there's a 100% survival rate in these 100 patients. And this was found many, many times in other studies as well. You might be familiar with the ALBIOS study, a study in sepsis and severe sepsis and septic shock patients from Italy, and it looked at the beneficial effects of the administration of albumin. Also, in samples of these patients, proenkephalin was measured, and again, clearly it's a relationship with renal SOFA score, so it's related to the severity of renal damage. But again, very interestingly, is if you come in with a high level on admission and it stays high, almost half of these patients will develop AKI. But if it's low the next day, then the chance of AKI is only 8%. And the reverse is true if it's the opposite way around. If you come in with a low level and it stays low, chances of AKI are really low. It's only 11%. But if you come in with a low level of AKI and it increases, then also the chance of AKI is 3 times higher. And this translates ultimately to mortality as well. If you are low and you stay low, or if you are high in penk and you get low the next day, these patients have the best survival. If it is high and it remains high, or if it's low and it goes to a high level the next day, these patients have a much more higher mortality rate as well. So this means that proenkephalin is like in between the AKI detection, and this is also very related to the mortality prediction. So this is really, really interesting. So based on all this data, our group actually measured proenkephalin, and we compared it not to creatinine clearance or to AKI diagnosis, but to the Iohexol gold standard GFR determination. And we did so in a small group of 23 patients with sepsis admitted to the ICU, and these were clearly unstable patients. They had renal function that was deteriorating or getting better at that moment. And what we found in these patients was a very good correlation between the proenkephalin circulating concentration in the plasma and the measured gold standard with Iohexol, which is not doable in normal clinical practice. One other item I want to address shortly is, does it work in kids? So I said that indeed in volunteers, in healthy people that are adults, the normal value is about 45. One of my colleagues did a study in children and compared indeed 100 healthy children to critically ill children. And again, it was found indeed that proenkephalin was associated in severity with AKI, stage 1, 2, and 3, increasing levels. But interestingly, as you can see on the left, is that the baseline level of non-AKI children, critically ill children, is about 400. So 10 times higher than in the adults. So the normal value is really age-dependent, clearly, but still there is this relationship with the development of AKI. And compared to other biomarkers, indeed, the area under the curve for penk was best in predicting AKI in critically ill children. And also of interest, the kinetics of it, the timing. So in these children, time after intubation is clearly very much differentiating between patients that might actually develop AKI or not. And you can see that within 6 to 12 hours, the difference is already there for proenkephalin in predicting AKI that might develop in children. So back to the kinetics of proenkephalin against creatinine in critically ill patients. We had a couple of questions on that because it would be great if we could detect a change in GFR earlier compared to creatinine. That's one. And it would be great if we could use proenkephalin to improve the estimation of the GFR, so the eGFR formula. I will go into that now. So we want to know this, and therefore we measured creatinine as well as proenkephalin every day in all-comers adult ICU patients. And we did so in over 600 patients. And if there was indeed an AKI diagnosis that they developed in the ICU, we looked at the creatinine kinetics and we compared this with proenkephalin. And indeed, what we found was that the increase in proenkephalin on average was 1 day earlier than the diagnosis of AKI. And so also the development of AKI could be predicted, right? So this, we know earlier that this patient will develop AKI. So overall, this area under the curve was very good, 0.82. And that means that if you look at the different threshold of proenkephalin, you have different sensitivities and specificities, of course. So you would have over 90% sensitivity if penk is below 50, and over 90% specificity if it's above 100. So realize what this means. If you have a patient with a low proenkephalin, you know for 90% certainty that that patient will not have AKI the day after. Or if proenkephalin is above 100, then you will have a 90% chance that this patient indeed will have AKI tomorrow. And it's the same for resolving AKI. Proenkephalin is earlier and might predict the decrease in creatinine. Again, in the same group, we measured when is creatinine coming down and how does the kinetics of proenkephalin relate to this. And we found again that on average, proenkephalin goes down 1 day earlier compared to creatinine. So that means, for example, that you have a patient with a high creatinine value, and you think, well, maybe this patient might need renal replacement therapy, and I will actually try to arrange that for this patient. If the proenkephalin level is already decreasing, then you can forget about that because next day creatinine will be decreasing as well. So this is really relevant stuff, I think. Again, another group looked at the proenkephalin levels and trying to predict who will need renal replacement therapy. And again, the area on the curve is about 0.79, really good. And so you can predict indeed who will need renal replacement therapy. So you might say again, well, you know it then 1 day earlier, but who cares? There's no treatment, etc. So imagine that you could actually know what your stock will be tomorrow. That would be great. You'll be rich and happy, and you won't even have to go to school if you know 1 day earlier what is going to happen. And I think with proenkephalin, we're able to detect acute kidney injury 1 day earlier. We can predict the occurrence of AKI within the next 5 days with a very good area under the curve to predict that using penk. And we can actually predict who will need renal replacement therapy in the next 2 days. And we can also detect a decrease in creatinine 1 day earlier on average. And so this is really relevant even in the absence of a treatment. If I repeat these slides from KDIGO with different things that you can do as secondary prevention, indeed, if you see an increase in proenkephalin, you might take these secondary preventions because you know that next day, indeed, there will be an increase in creatinine and AKI will be diagnosed. Now, proenkephalin, of course, is a new concentration. We're not used to it. We are used to looking at creatinine, and we are used to having an eGFR, an estimated GFR number. So that's why we did the second study. We wanted to make a model and look at different items that we measure in different patients to see if we can actually improve the current existing MDRD or other formulas that we have to estimate the GFR. So for that, we had access to 1,300 patients, over 1,300 patients. that had indeed measurements of Iohexol or iothalamate clearance as a gold standard, as well as creatinine values and proenkephalin values at that very moment. So these were patients with a measured GFR on average of 61, with a large spread, healthy persons that were actually kidney donor for a family member, but also critically ill patients. So a huge spread of patients that were either in steady state situations or in non-steady state renal situations. And so what we did was we used 60% of these cohort to develop a formula, an algorithm for the GFR equation, and we used another 40% of the cohort as a validation. And these were, we did just divide it up, not selected on any items. And so we could test the developing equations that we made. So what we did is indeed use a method using root mean square errors, and then you leave out several items that you are putting in the model, and then you will see which one are most important. What came out was the proenkephalin, the log value of it was the most important predictor of GFR of that moment. Number 2 was creatinine, and then the race and sex and age were much less important. So if you look at this root mean square error graph, it means that the most pronounced change was induced by proenkephalin, then a little less by creatinine, and then age and race did not actually contribute much more. So using these very complex methods, indeed, you are removing stepwise different items, and then penk was removed last, meaning that this is the most important variable to have a more accurate detection or estimation of the GFR. So if we look at the formula that we made from this, called the penk creatinine formula, and we compare it to the other formulas that are currently existing, the MDRG, CKD, EPI, and also including the most recent one of the CKD, the 2021 formulation that is excluding race and now is using a complete different formula, you can see that bias and precision is significantly better for the proenkephalin creatinine formula. So there's much less bias. It's even better than the recent 2021 CKD formula. If you look at the P30 accuracy, meaning that what is the percentage of the eGFRs that is within the 30% range of the measured, the Iohexol measured GFR, again, is higher for the pancreatinine compared to the MDRG and the usual CKD EPI formula, and it's not significantly different from the recent CKD formula. But if we split that up based on the category of GFR that the patients are in, you can see that indeed it doesn't matter much, and that the CKD EPI new one is doing actually worse in those patients with a very low GFR, but that the difference are in the group between 30 and 90 mils per minute per 1.73 square meters of GFR, that in that group, the pancreatinine formula is doing better than the other groups. And that actually the new CKD EPI 2021 formula is performing best in those patients with an eGFR above 90. But it's especially that group between 30 mils and 90 mils per minute that is relevant, because these are the cutoff values, for example, to adjust the dosing of drugs that are nephrotoxic or are renally cleared. So this is the group where it's really relevant to have the right estimation of the GFR. So the formula the algorithm that we made is depicted here. It's a really complex formula, but this will be published. It's submitted for a publication, and then everybody can use it, of course. So all you need to know is the age, the creatinine value, and the proenkephalin value. Put it in this formula, and then you will have the most accurate eGFR that we have found now. So my conclusions are of this webinar that, first of all, it's really relevant to realize that proenkephalin is a functional biomarker, not a tubular injury biomarker. So like creatinine or inulin is measuring the actual renal function. Compared to creatinine, it's more swift and it's more accurate to detect a change in the GFR. And this is for an increase as well as a decrease in GFR. And so using proenkephalin, we are able to detect this change one day before you will see the creatinine increase or decrease in that same patient. And I think to alert physicians treating these patients, if we can put the diagnostic clock ahead by up to 24 hours compared to the clinical clock that we use now with creatinine, this is really relevant and will make a change. You will do less nephrotoxic interventions in a patient, and you will adjust your policy if you would know that creatinine would be higher the next day. And finally, also an algorithm like the other formulas that are available is now available and is more precisely estimating the eGFR if you use the combination of proenkephalin and creatinine in these patients, and it will give you a number that you're used to because we use the estimated GFR every day. So based on that, I want to thank you for your attention. I hope you enjoyed this webinar, and I'm happy to take your questions if you have any. Thank you very much.
Okay, thank you very much, Professor, for this great talk on proenkephalin as kidney function biomarker and for sharing these exciting results on the new formula using penKid. Please type your question in the text box. Oh, we have already one question. So could the formula be applied at the emergency department and ICU?
Yeah, so the different patient cohorts that were used to actually build this algorithm were indeed partly steady state outpatient clinic patients, as well as patients in the ICU, cardiac surgery patients, septic shock patients, etc. So this is indeed a formula that we can use in all these patients. They're all compiled, and these are the data of the combination of all these patients. So yes, I think that's very well done. And so what we did is we divided up the 1,300 something patients that we had to build the algorithm and to test it. But what would be great if we publish it, that people that are using proenkephalin can also indeed validate the formula, and so we have more external validation at the same time. The issue, of course, is that normally nobody measures iotelamate or Iohexol, so we would never know the gold standard GFR. And so many mistakes are made in the clinic or also in literature that they compare it to creatinine clearance or creatinine levels, and then it's different, and people think, well, it's not correct because it's different what I'm used to. But actually, it's the creatinine that is not correct, because we have shown that indeed, if you compare to a gold standard, this is more precise, and you will indeed find discrepancies between creatinine and proenkephalin, but it's the problem of the creatinine. That's my main message.
Okay, thank you for the answer. One more question. Thank you for this clear and good talk. I would like to know if the GFR formula is applicable for all patient cohort and children.
So as I said, I think all adult patient cohorts, this is what we built on and where we validated it on. We did not test it in children. So this is a very good suggestion indeed that we should do it. I think it will be different maybe in children because, as I mentioned in the two slides in which healthy children and critically ill children were compared, in children with no AKI, they already have a much higher proenkephalin level compared to adults healthy person. So we will have to adjust the formula in children, because otherwise we will have a completely different eGFR estimation. So this is also something that is future work that we should look into to make sure if indeed it's only like we have to divide their proenkephalin level by 10 and everything stays the same, or that the whole formula needs to be different in children.
Okay, thank you. One more question. Is penk earlier compared to cystatin C?
So cystatin C is another functional biomarker, and indeed it has also less of the problems than creatinine, but still is not used very much in the clinic. There are other issues with cystatin C. For example, if you use steroids, the levels are influenced by that, and this is something that is done very much in the ICU. We do not have a direct comparison between proenkephalin and cystatin C, and we did also not have cystatin C available in the cohorts that we used, so we could not use it in the formula. It's also a relevant and interesting issue to show that indeed whether or not proenkephalin has additional value compared to cystatin C.
Okay, thank you. How often do you recommend to test penk in ICU patients?
Yeah, so as this is a more swift measure of renal function at that moment, normally we would measure creatinine once a day, and we see changes over time. And indeed, if we measure proenkephalin, then we see it one day earlier that the change is there. But that would mean, theoretically, that if you would, for example, measure proenkephalin twice a day, that you might be a little bit more early because of that. We only had data for once a day. So at this moment, I think if you are thinking about using proenkephalin to determine GFR renal function in your ICU patients, I think I would start with once a day as you do creatinine. And also you might want to do it in a group of patients, especially if you think this is a patient that is at risk of sudden changes in renal function because it's a patient with septic shock or norepinephrine, or it's a cardiac surgery patient that just came back from the operating room. These are the situations that renal function is really changing within a short amount of time. And so you might be able to pick it up earlier with penk. And so especially if you have plans for that patient that might be toxic to the kidneys, then it would be good to know if that patient is indeed at risk or not. So these would be the subgroup of patients that I would suggest to use it. And I would start with once a day. And maybe if we get more feeling with it, and indeed we find that it's helping to predict earlier, then it's a possibility to do it even twice a day.
Okay, thank you. The next question, thank you for this great presentation. And do you think penk is only useful to test in high-risk patients, potentially undergoing sepsis, or as daily routine?
Well, the thing is, of course, you can measure it in a daily routine, or if you want to do that. But I do think it's a trade-off between what would be the benefit and what would be the cost, for example. And so if you do it as like a daily routine measurement, you will pick out a couple of patients that you might have missed if you only measured creatinine. But this incidence will be lower compared to a group that is much more unstable and is likely to have a deterioration of renal function at that very moment that you will only see the next day if creatinine is measured. So if you want to have a high reward, the incidence will be much higher if you do it in that unstable group of patients to pick out the patients that will have AKI by the creatinine criterion the next day. But if you have the resources, of course, if you would do it in all patients, you will pick out a couple of patients as well, but the incidence will be lower, I think.
Okay, thank you. One more question we have here in the chart. Is there any difference between the formula performance in steady state and non-steady state patients?
Yeah. So to know if I correctly remember, I think in steady state patients it's a little bit better, and that makes sense because there are ongoing changes that make it a little bit worse in the non-steady state patients. But nevertheless, that's the problem in a much more pronounced way for the current formulas that we use based on creatinine levels. And we know indeed that we get these results that what the eGFR is in the lab value of our patients, but we know indeed that if there are sudden changes in GFR, that estimation is not correct. So it's much better if we add proenkephalin to that algorithm, as I showed. But still, if there are huge changes in renal function, it's clear that also with proenkephalin, then the results do get impaired during unstable situations.
Okay, thank you. And do you think the more precise estimation of GFR can also help in drug dosing?
Yes, I think that's one of the important consequences. So now we have drugs that we need to adjust based on renal function. And the reason is that the drug is never toxic by itself, or the drug is cleared by the kidneys. And then if kidney clearance is less, the dose has to be less of that drug. And so what we now use is many times cutoff values of a GFR of 30, for example. 30 mils per minute per 1.73 square meters. And so we actually looked at that in our 23 patients with septic shock, and we used the gold standard, and then we looked at the creatinine clearance methods and the penk related method. And we found indeed that if you use the gold standard with creatinine, many patients are in the wrong cohort. So they would have maybe a clearance of 28 mils per minute, but they would be in the creatinine cohort that they have a clearance of 48 mils per minute. And so you would not adjust your drug dosing in those patients because you're missing the acute deterioration of kidney function. And that was, we could show indeed that the wrongful determination in what cohort a patient should be was much lower with proenkephalin. So I think at this moment, this is one of the relevant consequences of knowing what is the exact GFR of this specific patient on this specific moment in time. And that is actually one of the ideas that we could do, that as an endpoint, are we able, if we use proenkephalin, are we able to improve the more personalized medicine dosing of drugs that are renally excreted, for example? Because it will be really difficult, of course, to show that there is a better outcome or survival if you use proenkephalin instead of creatinine to measure renal function. But if you can actually, as a soft endpoint, show that you are able to follow guidelines more precisely, for example, related to dosing of drugs, that would be also a benefit for these patients.
Yeah, very interesting, very important, this point. Thank you. Another question that we have here in the chat is, can penk be used from early recognition until recovery of kidney function? Monitoring, yeah?
Yeah, sure. So definitely. So one thing that we found was in our ICU all-comer study was that we detect the increase of creatinine 1 day earlier with proenkephalin increase. Then it peaks to the level that the AKI diagnosis is made, and also the diagnosis is preceded by an increase of proenkephalin. But also for resolving AKI, it's the same thing. The creatinine is going down, but the proenkephalin level is going down 1 day earlier. And this is also really, really relevant, I think, because you might have a patient that has increasing creatinine values, and you are contemplating that that patient might need to go on renal replacement therapy. Well, if at that very moment that creatinine is still increasing, the proenkephalin level is already decreasing, then it's very, very likely that the next day the creatinine value will also decrease because there is this lag time of 1 day. And so if you are thinking to start up renal replacement therapy in that patient, it might not be necessary because the next day the whole situation improves. So it's also really relevant, I think, not only to detect AKI and to detect it earlier, but also to detect resolving AKI 1 day earlier. So I think that's another interesting indication to use this. It's not only to show things go worse, but also relevant to show that things get better.
Thank you. We have another question here. Do you have any recommendation of prophylactic treatment if penKid is elevated, even though the patient didn't develop an obvious kidney injury yet?
No, it's an excellent question as well. And the issue is that at this moment, there's no data related to that. You can envision that indeed you would have an increase of proenkephalin as the trigger to give a treatment or to do preventive measures, and that this might improve outcome of these patients. The data is simply not there. There is indeed data on NephroCheck that shows that if in cardiac surgery patients, you have an increase of this tubular injury or stress marker, if you then actually give these patients and treat them according to the KDIGO guidelines, what we say that we do in all patients, but we don't in real life, they showed that indeed the incidence of AKI went from 70% to 30%, something like that. So a huge benefit in preventing the occurrence of AKI. And so this shows that if you know these things earlier, they do translate to a benefit in clinical perspectives of the patients. But to this moment, unfortunately, such a study has not been performed by Proenkephalin.
Okay, thank you very much. There is one more question regarding the biomarkers. Could you please shortly explain the difference of renal function and damage biomarkers and what their information mean for protective treatment decisions?
Yes, this is a very relevant differentiation indeed. So on the one hand, we have tubular injury biomarkers. And so these are mainly from tubular cells. And if the cells die, they release proteins, and you can measure this in the urine or sometimes also in the plasma. And so it's a measure of damage to tubular cells. At that moment, the function of the kidney does not have to be influenced yet. So GFR can still be good. And so these are tubular injury markers. And NephroCheck is even a stress marker. So a cell doesn't have to die before it's actually releasing the NephroCheck proteins. It's just being stressed. So this is a very early marker as well, but it might not completely relate to a decrease in function of the kidney. Another thing, NGAL is another tubular injury marker, but we know now that NGAL is also elevated if there is systemic inflammation. And of course, many ICU patients in particular, there is sepsis or some form of injury that is inducing systemic inflammation. And again, NGAL then loses its ability to correlate with AKI, especially stage 1 AKI, because the NGAL is elevated because there is inflammation, and then it's not so much more predicting AKI. So there are also shortcomings of that. And we do know that patients that show an elevation in the tubular injury markers, they are also experiencing less favorable clinical outcomes in the longer term, but this effect is much smaller than the effects of a decrease in clinical functional renal function. So there is some effect, but it's much smaller. So if you have an increase in tubular injury marker excretion, there is also some effect that your outcome is a little bit worse, but it's a huge difference between the clinical functional biomarkers like proenkephalin and creatinine in these patients. So it seems that you can have a little bit of injury, but it does not translate that much to the clinical outcome of these patients.
Okay, thank you for this clear answer. There is one question quite related to this previous one, and it's proenkephalin reflect the loss of kidney function. And is that happened before the damage to the kidney? And if so, how much earlier? Yeah, can we estimate that?
Yes. So I think there are two ideas about it. One is that the properties of proenkephalin are just by accident, so that it's a good measurement for renal function because it's filtered by the glomeruli and is not actively reabsorbed or excreted in the tubular space. So it's a really good measure of GFR just because of the properties of the protein. That's one thing. But the other thing is that the production of penK is also being mediated. And so this is an endogenous opioid. And so one other way of thinking is that the body will actually produce more proenkephalins if it senses that there is a problem coming. And so it's using that to actually signal to the kidneys that there is injury coming. And this is a very intriguing theory, I think, because one thing, as I said, is that the amount of opioid receptor expression in the kidneys is huge. It's only higher in the central nerve system. So why would the kidney have so much of these receptors if there's no function in actually endogenous opioids attaching to the receptor and giving some signal to the kidney? And so it could increase indeed prior to the actual damage to the kidney. So that's what the person that's asking the question is alluding to, I guess. And so this is really interesting, I think, but it's difficult to find out to what extent this is happening. So you have to think about it like you also have like BMP levels that is actually a signal to the heart that it's failing. It's also, so it's stretch of your atria that is producing that. And so the heart itself is signaling that it's failing. So this could be also signaling that injury is coming, kidneys, be aware. This is interesting as well, but I think it will be really difficult to show that this is the case, and you to detect that, to make sure indeed that if you increase penK, is this preceding the actual decrease in GFR. So it's my personal feeling that it's a little bit more the first thing that I said, that it's actually the properties of the protein that are making it a good predictor or detector of the GFR at that moment.
Okay, thank you. In the last 2 minutes, there is a last question here, very interesting. What can clinicians do thanks to penKid's one-day early prediction? What are the specific clinical benefits to improve AKI, to improve that's
quality of life?
Yeah, okay, quality of life of AKI patient.
Yes. So a couple of things. So one, as I mentioned in the presentation, is that there's no specific treatment at this moment, but the most important thing that we can do if a patient is developing or at risk for acute kidney injury is try to prevent further damage. And so if this is a patient that is on a nephrotoxic drug, like antibiotics, for example, or is using ACE inhibitors or NSAIDs at that moment, you would actually, if you would know that the next day there would be AKI, you would stop these drugs and you would look for alternatives. You would actually, I think, have more monitoring on that patient to make sure that there will not be hypotension, for example, if this is a septic shock patient, and you know that the next day he will have AKI. So then you would want to make sure indeed that the hemodynamic situation is as optimal as possible. you would maybe say, all right, we need to monitor urine output because this is a patient that is at risk tomorrow, and I want to make sure that we are doing the right things at this moment. So there are multiple things that we need to do to try to prevent further damage. And these things we are now doing if the creatinine is already increased and the damage is done. So we are just a day too late, I think. And therefore, I think it would be a huge benefit if we knew it one day earlier and we could take these measures one day earlier. The other thing is that it will be really, really difficult to show that if you do all these things that you improve quality of life of patients with AKI or once they leave the ICU, because there's a huge variation. You would need thousands of patients to show that difference. At the same time, I think, for example, when protective lung ventilation was found, and we learned that we have to use smaller tidal volumes, if you would do that in a patient, that patient would not improve all of a sudden or would be better. But we do know that in the longer term, mortality is lower, etc. We have less damage to the lungs. So it was implemented very easily, more or less, because we do something that is doable and we prevent problems and we do improve survival or quality of lives. I think it's a similar thing that if we can do this and we know we are actually acting one day earlier, that people would actually accept that and implement that, because even though we are not able to show that they have a better quality of life, it makes sense to just not to wait that day longer. And last thing is that there's also observational data from Finland that shows that if a patient is needing renal replacement therapy during his or her stay in the ICU, even if it's only 1 day of renal replacement therapy, then that patient is 100 times more likely to develop end-stage renal disease within the next 5 years. 100 times, even if you need renal replacement therapy for only a day. So there's a huge amount of loss of renal function. And even though the patients go out of the hospital with a normal creatinine level, we do not realize that actually they lost a lot of muscle tissue, and therefore the creatinine is lower. And so their similar creatinine levels that they had before the ICU admission is actually meaning that renal function is much worse because there's less muscle tissue. And then over time, we do know that renal function slowly deteriorates if you get older. But in these patients, if they were on renal replacement therapy for 1 day or a couple of days in the ICU, that slope is much more steep. And that means that they get worse much more, and they end up as end-stage renal disease patients that need chronic dialysis. And so the risk is 100 times higher. It's a huge effect. So if we know earlier that AKI is happening and we can take measures to better treat that patient, hemodynamically monitoring, leaving out nephrotoxic influences, we can have a really big impact on the long-term outcomes of these patients.
Okay, thank you very much. It was a very clear answer. And we come to the end of our webinar. I would like to thank all questions, all participants. It was very great to have you here. And special thanks again for Professor Pickers to take the time and to give this great overview and share the recent data with us. So with that, thanks again and good evening to everyone. Bye.
And thank you very much. Have a good day. Bye-bye.
Bye.